We are picking up on slide number 48, which is nicotine pharmacology slide. So this is a picture of nicotine, the molecule. And as you know, as with most things, the pharmacology depends on the delivery route. And to the tobacco company's credit and to their pocketbook, they have come up with the ultimate nicotine delivery system, and that is the cigarette, because when you smoke a cigarette, the nicotine reaches your brain in 10 seconds. And that's why this is harder to quit than crack cocaine. So I think most people would think, oh my gosh, you know, crack cocaine is the hardest thing in the world to quit. Actually, the hardest thing in the world to quit is nicotine, and it's because of the delivery system. The half-life of nicotine is 2 hours, which means that you're going to have to refuel many, many times during the day in order to keep your nicotine blood levels and your brain nicotine levels at a nice steady state. So that's why sometimes with our clients, they're the chain smokers. It's one after the other. Nicotine is broken down to something called cotinine in the liver, and the reason that that is important is because cotinine is what the insurance companies use to figure out whether or not they should charge you a higher premium. So the insurance companies certainly don't believe you if you say, well, I'm a non-smoker. What they do is they do blood tests on you or urine tests on you, and they look for cotinine, because cotinine has a half-life of 18 to 20 hours, and therefore cotinine can let the insurer know whether or not you've been exposed to nicotine over the previous 2 to 3 days. As I understand it, there's places such as the Cleveland Clinic up here in Cleveland where they won't even hire you if they find cotinine in your system. They're only going to hire from now on non-smokers, which brings up to me a whole lot of sort of ethical and legal issues, but that's how serious I think this country has gotten about the costs of even hiring and insuring a smoker. So cotinine is the magic little chemical or molecule that's the breakdown product. There's also something called anabasine, and anabasine is a tobacco alkaloid, which is actually not so much a breakdown product of nicotine, but what it does, anabasine can help let you know, was the person still smoking, or were they merely using their nicotine replacement therapy? If they're merely using their nicotine replacement therapy, you'd have a negative test. If they were still smoking, then you'd have a positive test. Now, the answer to the question that I don't know is, what if they're smoking and using their nicotine replacement? I don't know what would happen to the test, but that one has always been a curiosity to me. So those are some things that you may not have heard before. The next slide, slide 50, shows you some of the genetics of nicotine dependence. And similar to the way that we've studied the genetics of alcoholism, we've done twin studies. And twin studies reveal that there is actually an inherited component to tobacco use and dependence. And we have seen familial transmission of smoking across generations. That's been observed repeatedly. And just like any other addictive disorder, and just like most mental illnesses, these are complicated illnesses, and so it's not just the genes and it's not just the environment, it's both of them together in very complex ways that are involved in whether or not the end product is a person that's a smoker. So it's definitely genes and environment kind of woven in a fabric is one way to look at it. So the actual pathophysiology of nicotine activates a particular receptor in the acetylcholine family. The particular receptor is the alpha-2 beta-4 nicotinic acetylcholine receptor, and this is the 1 or 2 times in the year that I get to say that, so it's a lot of fun for me. So nicotinic acetylcholine receptors are pentameric ion channel complexes. What the heck does that mean? It means that it's a little hole in the membrane of a cell, and surrounding that little hole are 5 little proteins. And these 5 proteins are different combinations of alpha units and beta units. And so alpha and beta are just the names of the different protein complexes. So just as you can have an alpha-2 beta-4 receptor, you can have an alpha-1 beta-2 receptor, and et cetera, et cetera. So there's all different kinds of acetylcholine receptors because, as you know, acetylcholine is involved in all kinds of diseases, you know, up to and including Alzheimer's and other different diseases. So acetylcholine is ubiquitous in the brain, but when you're talking about nicotine addiction, you're talking about the alpha-2 beta-4. Okay, so that's what that is. When you activate the alpha-2 beta-4 nicotinic acetylcholine receptor, you get an increased secretion of dopamine. That's the important part. you get an increased secretion of dopamine in the nucleus accumbens. The nucleus accumbens is sort of the grand central station for reward and pleasure in the brain. That's why it's important. Okay, the other thing that's important is that the receptors are rapidly desensitized by nicotine. This means that the person smoking the more that they smoke, the less sort of, fun they get out of each subsequent cigarette in that sort of daily period. And so what happens is that first cigarette of the morning is kind of like the most satisfying. I mean, so all these things that you hear from smokers, if you yourself are a smoker or a former smoker, there's actually a biological reason for them, and we're finding more and more out about it all the time. We do know that these particular receptors, the alpha-2 beta-4s, are found in the pleasure and reward system, and they're also found, which is dopamine, and they're also found in the locus ceruleus system, which is norepinephrine driven, and that has to do with attention and cognition. So again, is the reason that this may help some people with schizophrenia think more clearly, at least in the short run, is because it hits the locus ceruleus in the attention and cognition centers of the brain. Now, I wish it was that easy, right? That it was just dopamine. It's not just dopamine. Because, like I told you, acetylcholine is ubiquitous in the brain, and interestingly, nicotine itself leads to the release of a number of neurotransmitters in the central nervous system. Not only dopamine, not only norepinephrine, also glutamate, also vasopressin, also serotonin, also GABA, also endorphins. Okay? Why do we care? Why is that important? Well, you don't have to memorize the names of those chemicals. What's important is that this is what causes nicotine to have its interesting effects. At the same time that it calms you down when you've crashed your car and you're like, oh my God, I got to have a cigarette because I'm so anxious I don't know what to do. At the same time it does that, it also can stimulate you and make you concentrate better. So it has this calming, stimulating, and reinforcing, meaning addictive. Reinforcing is just another word for addictive. So it's stimulating, calming, and addictive all at the same time. There's not a lot of substances out there that are that complex. So, for example, if you think of alcohol, alcohol just does one thing. It turns everything off. It shuts off the central nervous system. Or, opiates just hit the opiate receptors, and cocaine and speed just turn on the dopamine. Whereas nicotine is much more complicated than that. It's leading to the release of lots of different neurotransmitters, which I think also makes it harder to quit, because you've got to sort of break through all of these neurotransmitter systems when you're getting well. Okay, so the neurobiological connection. As I already alluded to earlier in this afternoon, smoking can interfere with the metabolism of psychotropic medications. So you may need potentially higher doses to get the same therapeutic effect that you would expect in a non-smoker. Okay? So in other words, and again, I can't say that for every single medication, it's a 50% decrease or it's a 10% decrease. It's just that with particular medications, and this is where I would have you look in your folders and look at the list of medications. It's labeled drug interactions with tobacco smoke. When you look at those different medications, you can see increases, in different levels of things. The other thing that happens is as the person quits smoking or decreases their use of tobacco, side effects of medications may increase because now they're seeing more medication. Their brain and their system is seeing more medication, even though the only thing that's changed is the smoking issue. So of course that's going to have all kinds of implications for when we're helping our clients to quit or cut down. So what kind of medications are we talking about? Not just psychotropics, but others as well. So when a person quits smoking, you might expect levels of these medications listed on this slide, as well as the medications listed on the list in your folder, to increase. So you need to be careful. So, Haldol levels can increase, Zyprexa levels can increase, but things like Tylenol levels can increase. Caffeine levels can increase. Coumadin or warfarin levels can increase. Some of those medications are quite dangerous. And again, do I have, news to tell you for sure it's going to be 10% or 20% or 50%. I don't have all those things memorized. That's why we have, pharmacologists and pharmacists to help us with that stuff. I think the learning point or the lesson is let's count tobacco in as something that can potentially mess with all of the other medications that our clients are taking. That, to me, is the take-home point. So no, you don't have to memorize a list. The lists are there. You can keep the list around for reference, but the important point is you can see changes. Okay, so again, to summarize on this little section, tobacco use, as we know, contributes to morbidity and mortality. Folks that have schizophrenia and other severe mental illnesses do get more toxic exposure per cigarette. This is going to impact the pharmacological treatment because of this direct neurobiological connection, and it's going to have direct implications for intervention. Okay? So, all right. So, as if you needed it, there are 5 reasons that you should use pharmacological treatment in tobacco dependence. Okay? There's 5 potential reasons. The first reason is that you can reduce or totally get rid of withdrawal. That's a good thing, because it's the withdrawal that makes the person get up in the middle of the night and want to smoke a cigarette. So if you can get rid of withdrawal, you can get rid of one of the things that keeps the person smoking. The second thing that can help is that you can block the reinforcing or the feel-good effects of nicotine. And if you can block the feel-good effects, then perhaps the person won't continue to go back to that substance. Very similar to what we do with naltrexone and alcohol. Naltrexone blocks the reinforcing effects of alcohol. Other medications that we're going to talk about block the reinforcing effects of nicotine. Pharmacological treatment, and I'm thinking specifically of bupropion or Wellbutrin in this case, can be used to manage the negative mood states that can happen when you're trying to quit smoking. So we know that there's a direct relationship between smoking and depression, that more people with depression smoke than people that are undepressed, and so on. So there's definitely something about the smoking. Might it be the nicotine? Might it be all those receptor systems that it's impacting, the serotonin, the norepinephrine, that causes nicotine, quote, to be its own little antidepressant? When you take the nicotine away, that person gets depressed. That makes it hard for them to quit smoking because they feel so depressed. So when you use pharmacological treatment, you can help manage those mood states. The other thing you need to do, if you think about it, is you need to unlearn all of that smoking behavior that you've learned over the years. So that's all of the associations. I smoke when I wake up in the morning. I smoke when I drink coffee. I smoke when I drink beer. I smoke after a good meal, etc. I smoke only in my car. I smoke when I walk the dog. So you got to unlearn all of those smoking behaviors, and the medications can help a person do that. And then finally, it's quite a cost-effective treatment. And when you look at, I believe we may have a slide or two on that, when you look at the cost of, what does the treatments cost versus the cost of either continuing to smoke or the medical costs associated, it really is, in terms of risk-benefit, it's of a great benefit. There are currently 7 FDA-approved pharmacological treatments for nicotine dependence. Those 7 treatments are listed here. We're going to go through them one by one. I like this little cartoon. It's one of my favorites. Here the gentleman has put the nicotine patch over his mouth because he thought that's how it would help him quit smoking. And it looks like his wife or his partner there is quite happy with that. So works for her. Okay. This slide is to remind you that nicotine isn't what kills you. It's the smoke and the act of burning the tobacco that releases the 4,000 compounds, including cyanide, formaldehyde, carbon monoxide, and acetone, nail polish remover, into your system, and as well as the more than 60 carcinogens into your system, such as benzene or nitrosamine, things we know that for sure cause cancer. So it's the act of smoking, burning the tobacco, that breakdown by burning is what releases all of the poisons. That's the thing that we're trying to get away from. So, because I think, there's that myth, nicotine is bad for me. Well, no, nicotine is the thing in the cigarettes that makes it addictive. That's what makes you come back to it, but it's actually smoking, the act of smoking, that's what kills you. Okay? So nicotine in and of itself does not cause cancer. the way that nicotine is delivered in a cigarette causes lots and lots of cancer. Okay? Nicotine itself is not a significant risk factor for cardiovascular events. And the risk-benefit ratio does support using nicotine medications over using tobacco. That's a no-doubter. Okay? You could take that one to the bank. All right, so let's talk about the 5 different kinds of nicotine replacement therapy. But I'll talk first in generalities. So nicotine absorption via NRT is much poorer than, of course, the 10 seconds of the nicotine getting to your brain as if you would smoke a cigarette. So what happens is, in general, you're going to get a lower dose delivered. Nicotine replacement therapy is also poorly orally absorbed because it gets broken down very quickly by your liver. That's why we deliver it through your skin, or that's why we deliver it through your cheek, because it's not going to get well delivered if you swallow it. Okay? Because of the lower dose and the poor absorption, nicotine replacement therapy is going to be less rewarding than smoking. This is going to cause your patients and your clients to say, this isn't working. Okay? There's 2 other reasons why your clients will say this isn't working. The first reason is you may not be giving them a big enough dose. I think that's probably the most common as a person is starting out with prescribing this stuff. That's the most common freshman mistake, is that we're not given a high enough dose. On top of that, the third reason is you've got poor compliance. So the person may not be taking their medication exactly the way they're supposed to take it, or they may not know how to use the medication. Chew and park, that's what I'm talking about, but we'll get there. So if you, the clinician, don't know how to tell your patients how to use it, that's where you're going to run into trouble. So hopefully we'll get some of that cleared up today. This is just a slide, a very nice slide, something again that we've known for many, many years, and that is that the cigarette, within a span of approximately 5 minutes, gets the nicotine levels in your brain up to 25, which is that very top dot on the slide. Then you can look at the nicotine gum, which is the lowest line on the slide, and you can see that you don't get any peak whatsoever. You get a very gradual increase and then a plateauing. And it takes quite a while to get there. And then the thing in the middle is nicotine nasal spray, NNS. And nicotine nasal spray does mimic that cigarette, but not exact. So you get maybe a level of, 13, 14, but it's not anywhere near the 25 level, 26 level that you see with actually smoking a cigarette. So when your people tell you this isn't working, you can whip out this slide and you could say, it seems like it's not working, but yes, in fact, it actually is working. You are getting a level of nicotine in your system. So kind of hang in there. That's why a lot of people that use the patch also have to use the gum. And people that, use the nicotine nasal spray, they might also want to use the lozenge. You got to mix and match because it's never going to be as good as actually smoking a cigarette. The cigarette companies already figured it out. And they've got a patent on it, right? So if only we could deliver Zyprexa through cigarettes, right? Wow, we wouldn't have any psychosis at all, would we? Okay. So there are, as I already said, there are very few reasons not to use NRT. Here are the reasons not to use NRT. Be very cautious if the person has had a recent heart attack, myocardial infarction, MI, not motivational interviewing. Myocardial infarction, okay? It's a different set of alphabet soup. What do I mean by recent? 6 weeks or less. So if you've had a heart attack in the last 6 weeks, you're probably, the FDA says you shouldn't be using patches, okay? Now, I will challenge the group and say, okay, so what are we supposed to tell our patients to do after they've had that heart attack? Go back to smoking? You know what I mean? So to me, it's a very interesting position that we're all put in. The other thing is if the person's a light smoker, and light smoker means that you smoke less than 10 cigarettes per day. The FDA also says maybe you won't need a nicotine replacement therapy, maybe you will only need behavioral therapy if they are a light smoker. You also have to be very cautious if the person is pregnant or breastfeeding. You also have to be very cautious if the person is under the age of 18 because none of these products are FDA approved for teenagers. The side effects of nicotine replacement therapy as a class are basically local side effects. Systemic side effects are much less common. Again, this is the part of me that always goes back to the concept of harm reduction. If a person had a heart attack 6 weeks ago, would I rather them be smoking cigarettes or have a patch? It's a very interesting question that I think most clinicians find themselves in at one point or another. If a person is pregnant, would I rather have them continue smoking cigarettes, or would I rather talk to them about the risks and benefits of using a patch? Interesting. So in other words, we can get into more trouble as clinicians by giving a pregnant woman a patch than by allowing her to continue to smoke. I think that's a little bit backwards and interesting. Okay, so let's talk about the nicotine transdermal system, or the patches. You get the nicotine through your skin. It's delivered in a steady dose. It can be applied anywhere on the upper body, so your arm, your back, etc., anywhere on the upper body. And it can be reapplied in a new site at the same time every day. The worst thing that you'll probably get is a skin reaction. Some people find out that they cannot sleep with the patch. Some people notice that their heartbeat is a little bit faster when they wear a patch. So for some people, you have to take the patch off before you go to bed at night, and then it allows you to sleep a little bit easier, whereas some people could sleep the entire night with the patch on. So you just have to kind of work it out with your particular client. This is what I was alluding to earlier. 1 milligram of nicotine patch equals 1 cigarette. If you have a 2-pack-a-day smoker, 21 milligram patch will not cut it. There's 20 cigarettes in a pack. You have a 2-pack-a-day smoker, guess what? You're gonna need 2 patches. And they're not even gonna like it anyway because of that slide I showed you with the cigarette, taking you all the way up to 25. The gum and the patch only take you to a nicotine level of like 10. And then you're gonna, sometimes people will underdose and only give you 1 patch, even if you're a 2-pack-a-day smoker. So you really, and then I even was talking to somebody last week who said, well, I have a person with schizophrenia who smokes 3 packs a day. So does that mean I'm supposed to give them 3 patches? Now, I can honestly tell you, as an addiction psychiatrist, I've never given anybody 3 patches a day. But theoretically speaking, my worry would be that if I only gave them 2 patches a day, I'd be underdosing them. So again, and when you read the fine print of the patient information, I think some of the fine print still says, oh, you shouldn't have more than 1 patch per person per day. And again, it doesn't go along with what we know is the science, which is 1 cigarette equals 1 milligram of the patch. So, and how long should you be on the patch? Well, again, if you read the patient labeling or you read the FDA labeling, it says you should be on the patches for 2 to 6 weeks and then, discontinue at the discretion of the treating physician. When you're dealing with people that have severe mental illness, I recommend, and I've read other recommendations that say that you might need to have them on the patch for longer. What do I mean by longer? I mean 12 weeks, 24 weeks, or maybe even longer. So that's the part, I think, that becomes off-label when you're dealing with people that have serious mental illness. It's not the amount, because we know how to do the amount, it's the duration of the treatment, okay? Thank you. Nicotine patch, here's some advice to give your clients. Pick a time of day that you want to put it on. Morning is usually the best. You want to rotate your patch placement on a daily basis. Let me get to the right page here. And I already said this, if you have trouble sleeping with the patch on, remove it at night. It may seem obvious, replace with a new patch every day, and never cut the patch. And I will never forget this story, and I tell this story every time I train. And when I was in a training in New Jersey, being trained about how to tell people with schizophrenia how to use the patch, there was a story of a gentleman that had schizophrenia, and he came back to the office in 2 weeks, and he had 14 patches on his body because nobody had ever told him that you take one off and you put another one on. There's this level of sort of cognitive dysfunction and concreteness that you need to be very concrete when you're telling your clients what to do with this stuff, okay? Take off and replace with a new patch daily in a different part of your body, okay? This is an example. If you follow the numbers, this is very similar to what people do with diabetes. You have to rotate where you inject yourself with the insulin. You also have to rotate where you put your patches on. So you can follow this picture, the front, the back, the 2 sides of yourself, or you can just come up with your own pattern but the point is to do the rotation. Okay, so let me see here. Okay, so that was the patch. And then the nicotine gum is in fact an FDA-approved over-the-counter medication. You chew it over 30 to 60 minutes, and you don't just chew it, you chew and park it, and there's an actual slide on that coming up. So the starting dose, if you are a mildly dependent person, is 2 milligrams up to every hour. If you are a heavily dependent person, so smoking 25 or more cigarettes per day, it's 4 milligrams up to every hour. And there should be no more than 24 milligram pieces or 30 2-milligram pieces in a given day. That's a lot of chewing and parking. The side effects of this, as you may imagine, mouth soreness from all that chewing, indigestion, sore throat, tachycardia. This can be reserved, or you can think of this as something to use if somebody is allergic to the patch. The other thing that people do is they do it in combo. So they would have the patch, they would use the gum for breakthrough. That's what we do on the inpatient psych unit. You know, we give you a patch, we give you gum for breakthrough because you can't smoke when you're on the unit. Nicotine gum is not like normal gum. You have to chew and park. So you chew it until you feel the peppery sensation. Once you feel the peppery sensation, you park it in between your teeth and your gum, teeth and the side of your mouth. And then it'll lose its peppery flavor. You have to chew it again to get the peppery flavor, and you do that. And so each piece, you'll be able to chew it about 10 times before it loses the pepper altogether. So it's about a half hour per piece. Okay? You're only supposed to use one piece of gum at a time, which is too bad because I like to chew like 3 pieces of gum, but you know, one piece at a time. And you don't want to drink anything acidic, coffee, juice, or pop, or soda, depending on where you live, for 15 to 30 minutes before and after every piece. And also you don't want to swallow it because that might make you very sick. So yeah, it's not just like a regular piece of gum. And again, with proper education of our clients, they can learn how to use this. So again, here's a piece of, I think it's Nicorette. Chew it slowly. Stop chewing it when you notice the peppery taste or the tingle. Park it between your cheek and your gum. And then when the tingle fades, chew it again. So chew and park. I've never been a smoker, so I don't know what the peppery taste feels like. So, okay, nicotine lozenge. This is also an FDA-approved over-the-counter medication. What you do is you dissolve it in your mouth over a 30-minute period. The dosing is quite similar to the dosing for the gum. It's 2 milligrams if you're mildly dependent, up to every hour, 4 milligrams if you're heavily dependent, up to every hour, no more than 5 lozenges every 6 hours, or no more than 20 in a day. Again, you can use it to supplement your patch. Here's an example of where you can use the Fagerstrom test, which is the first question is, you know, how soon after waking do you smoke your first cigarette? So if you smoke your first cigarette within 30 minutes of waking, you're going to want to use a bigger lozenge, 4 milligram. If it's more than 30 minutes after waking, you're going to want to use a smaller dose. So there's an example of why that question might be important. You're not supposed to chew the lozenge, bite the lozenge, or swallow the lozenge. So in that sense, it's similar to chew and park. You want to move the lozenge from side to side of your mouth. So not exactly a lifesaver. Well, I guess it could be a lifesaver. Pun intended, eh? Again, don't take more than 1 lozenge at a time. Don't take 1 lozenge immediately after another. Remember, you're trying to do 5 lozenges in a 6-hour period. And then don't eat or drink while you're using the lozenge. Don't eat or drink 15 minutes before or 15 minutes after using it. Boy, that might help you lose weight. Can't eat or drink. Okay, nicotine inhaler. The nicotine inhaler is misnamed. It should be called the nicotine puffer, but we didn't have any say in naming it. This is a prescription-only medication. It comes with a mouthpiece and it comes with cartridges. And so in the first few weeks that you're using it, you can use anywhere between 6 to 16 cartridges per day. 16 is the max. What you do is you puff it's like a powder, a fine powder. You puff that powder to the back of your throat. You do not inhale the powder into your lungs, because what happens is that it gets absorbed through your cheeks. So you don't want it to go all the way into your lungs. You just want to absorb it into your mouth area. So you puff frequently on this little plastic thing for about 20 minutes till the cartridge is used up. And once you start a cartridge, you don't necessarily have to complete the entire cartridge in one sitting. So
this isn't also one of those situations, especially if you have someone that has breathing issues, asthma or COPD, where they've been put on an actual inhaler, where the point of those inhalers are to get it deep into the lungs. You need to make sure that you help the person understand that this puffs into the mouth and the back of the throat. So that's why the use of the name inhaler can be a little misleading for folks, because especially if they're used to traditional inhalers, it's a very different way to use it.
So here's a picture of somebody using the Nicotrol inhaler. This is a picture from the Pfizer company. So the nicotine is getting absorbed in the mouth and throat. It says that right there. And you may have to use it longer and more often at first to help control the cravings. And of course, some people like it because it mimics the hand-to-mouth movement. So that's the other, it's the same movement, like an e-cigarette. Okay. So then for, let me get my point here. For the oral NRTs, which is the gum, the lozenge, or the inhaler, just stress to your clients that the nicotine is absorbed through the mouth. One thing you may also want to stress is you may want to encourage people to use it on a set schedule. So some people, maybe say a person that doesn't have severe mental illness, can use this as needed for cravings. A person that has a lot of addictive illnesses and has a severe mental illness, you may want to encourage them to use it on a set schedule. So use it hourly, or use it every 10 minutes, or use it every half hour to start to break the addictive behavior. Again, it's going to vary based on the client that you're working with.
And the other thing that we know is, as Chris was saying before, it's not as effective as the cigarette. So if someone goes for when they have a craving and they take one of these products, by then it's almost too late.
Yeah.
By the time you're feeling the craving, it's kind of too late to then counteract that withdrawal in an effective enough way that the person feels relief. So again, getting on a set schedule is going to keep that steady state of nicotine that's going to help the person not feel the withdrawal and not go through those problems. So that's the other argument for doing a set schedule versus when you feel the craving, go ahead and take it.
The last nicotine product is also prescription only. That's the NNS, or nicotine nasal spray. The recommended starting dose is 1 to 2 doses per hour, and the maximum of 5 doses per hour. 1 dose is actually equal to 2 sprays. So that's another little detail that you have to get across to folks. So that 1 dose means 1 spray in each nostril. And you can have a minimum of 8 doses per day and a maximum of 40 doses per day. So basically, tilt your head back, spray once in each nostril. Don't breathe while you're spraying it, because then you'll get it in the back of your throat and your lungs. And you want to wait a little bit before you breathe through the nose again. And then you also want to wait a couple minutes before you blow your nose. So again, it's not too complicated, but there may be questions that come up, and it's important to know the details. So to summarize on all NRT, which is all 5 forms of nicotine replacement therapy, when you look in the little blue book, the practice guidelines, the practice guidelines advise the use of nicotine replacement therapy for all patients that are attempting to quit smoking. And one of the reasons for this is because when you add nicotine replacement therapy to behavioral treatment, you double the quit rates. I will say that again, you double the quit rates. If we have anything in medicine where you double anything or cut anything in half, that's impressive. So that's why I said it twice. You're going to double, there's a third time, double the quit rate if you add NRT. And when you do combination treatment, You're mixing the patch plus the gum, the patch plus the lozenge, the inhaler plus the lozenge, whatever. When you're mixing and matching this stuff, you can actually have quit rates as high as 50%, which are phenomenal, because the quit rate, if you're just trying to quit cold turkey in a year, the quit rate I think is at 7% a year. It's a very small number. So if you can get that 7% up to 50%, you're helping more people quit smoking. So let's get off of the NRTs and go over to Wellbutrin and Chantix. So Bupropion is an FDA-approved treatment for smoking cessation. It is most helpful if you pick a quit date and start your Wellbutrin two weeks before that. It doesn't help you much if you start it the same day that you decide to quit smoking. That's not the way to do it. What you want to do is you want to dose it 150 milligrams a day for 3 days, then 150 milligrams twice a day, and then a week later, quit smoking. So that's how it works. Of course, it requires a prescription. So Bupropion is a non-sedating/activating antidepressant. It is going to affect norepinephrine. It also affects dopamine, and of course, it affects the nicotine receptor. The contraindications to this medication is if the person has a known seizure disorder or an eating disorder, and you're using the immediate release formulation, you can get into some risks there. Usually with the SR formulation, you're not getting the same level of risk. The side effects include insomnia, dry mouth, headache, activation, and weight loss. And as I already said, it's marketed as 2 different things, both Wellbutrin and as Zyban. Same pill, same exact molecule. The effect of Bupropion is actually independent, which I think is interesting, independent of whether the person is depressed or not, independent of whether you're male or female, and it's independent of race. So you don't have to be depressed to use Zyban as a smoking cessation agent. That's the bottom line, because some people say, oh my gosh, I can't give an antidepressant to somebody who's not depressed and expect to get the same effect. You'll get the same effect on smoking cessation, interestingly enough. It works in people who have actually failed nicotine replacement therapy. So if you're a patient, you tried with the patch, you tried with the gum, you tried with the lozenge, and it didn't like it, it didn't work, think about Wellbutrin. So it works in people that have failed it. It works in people who have failed Wellbutrin in the past, interestingly enough. So retreatment can be effective. And they've also done combination studies, so you actually get better results when you combine it with NRT. Okay, so that's Wellbutrin. And then the last one is Chantix or Varenicline. And remember way back when we were talking about the physiology, and I told you it was the alpha-4 beta-2 nicotinic acetylcholine receptor, which is where nicotine works. Well, what they have discovered in the last, I think, 2 years now, is that there's actually a medication which is specifically targeted at that receptor, and in fact, it's a partial agonist. It's a partial agonist at the alpha-4 beta-2 nicotine receptor. And what do I mean by partial agonist? What I mean is, rather than turning on the receptor all the way to 100%, the partial agonist only turns it up to, say, 50%, and then it stops. It doesn't go any farther. So it's like having a volume dial that only goes up to 5 instead of going up to 10. So 1 milligram twice a day dose is superior to placebo, and it's also superior to Wellbutrin in a 12-week trial. When you added an additional 12 weeks onto the original 12 weeks, that actually prevented the person from relapsing back to tobacco and nicotine. The most common side effects of Chantix are listed there. Particularly what you will hear about is the nausea, the vivid dreams. You may also hear about some of the other side effects, but the nausea and vivid dreams are what's going to cause the phone calls. The discontinuation of this medicine has a similar rate to placebo. Again, Varenicline is meant for people who are in the preparation stage or the action stage, not meant for your pre-contemplators or your contemplators, because you have to know what your quit date is. So you have to start this medication 1 week before your quit date. So on days 1 to 3, you take a half a milligram a day. On days 4 to 7, you take a half a milligram twice a day. And then from day 8 till the end of your treatment, whenever that may be, you take 1 milligram twice a day. You usually take it after you eat, and you take it with a glass of water. The only reason that you'd have to change the dosage around is if you had severe kidney problems or if you were already on dialysis. In that case, you'd have to decrease the dose. This medicine has not been studied in pregnant or breastfeeding women, so I can't comment on that. What you do with this medicine is you would continue it for 3 months or 12 weeks, even if the person hasn't been smoking at all. Just keep taking the medication. One of the reasons they're not smoking is because of the medication, and you can take it up to 6 months. One thing that you are not supposed to do is you are not supposed to use nicotine replacement therapy with Varenicline because it's kind of defeating your purpose. You're giving the person nicotine so that it can get to the nicotine receptors. At the same time, you're giving something that sits on that receptor and only lets it work 50% of the way. So there's not a whole lot of good reason to mix the two. Having said that, just a month ago, I was in San Francisco at the American Society of Addiction Medicine meeting, and a gentleman, doctor from Vancouver, basically said that in his smoking cessation clinic for severely mentally ill people, he had some success in the hardest to treat smokers with the combination of Chantix with nicotine replacement for breakthrough. It was fascinating to me. So again, you always learn something new every day. I guess is the point of that. But in general, from a psychopharm standpoint, it does not make psychopharmacological sense to mix NRT with Varenicline. But the real world is not always like psychopharmacological world. So there are no published studies that we know of as of approximately a year ago of using Chantix in the severely mentally ill population. I know that there's researchers across the country that are doing those studies right now. Okay, what happened with Varenicline and why you may have heard it on the news is that it got some FDA warnings. So it got approved, I was mistaken, it got approved 4 years ago, not 2 years ago. It got approved 4 years ago. In November of 2007, the FDA put out an early communication, excuse me, and then by February of 2008, they had put out a public health advisory, and then by July of 2009, they had actually put out the black box warning, or the FDA boxed warning, not only for Chantix, but interestingly also for Zyban. So, what is the warning? The warning is serious neuropsychiatric symptoms, including changes in behavior, agitation, depressed mood, suicidal ideation, attempted suicide, completed suicide, and vivid dreams. What's interesting is that some people had symptoms due to nicotine withdrawal, but some people were taking the Varenicline and had not yet quit smoking. So there's this controversy. Did the person have these serious neuropsychiatric symptoms because of nicotine withdrawal, or did they have the serious symptoms because of the Varenicline? At this moment, to the best of my knowledge, the jury is still out. There is an association, but there's no causation. And I have talked to Pfizer reps, and they've told me that, and there isn't anything in the literature that I found to date that goes against that. So there is no causation, there's a correlation. So you got to take that into account. Okay? So that's, I think, the challenge. The biggest challenge with Varenicline is that, particularly in behavioral health settings, we already treat people that have very serious mental illness. And do we want to take the risk, albeit a very calculated risk, do we want to take the risk to actually put them on this medication knowing that it might actually cause their depression to get worse or their suicidal ideation to emerge, etc.? So I would be interested when we get to our question and answer period to hear about doctors and nurse practitioners and other counselors' experiences with people that have been put on Varenicline and had a serious mental illness as to whether or not they had a bad outcome. Because what I think happens, as in most of medicine, you only hear about the bad outcomes. So we don't hear about the hundreds and thousands of people who have schizophrenia or depression or bipolar, take Varenicline and quit smoking, and nothing bad ever happens to them. We won't ever hear about those. What makes the news, what makes the headlines is, hey, this person took Varenicline and then they killed somebody, or this person took Varenicline and then they killed themselves. So I really think, again, in sort of a spirit of myth busting, if anyone has a story out there or an anecdote about a person that had a serious mental illness and was able to quit smoking using Varenicline and didn't have any bad outcomes, I'd love to hear about it. Okay, so here's some, I told you we'd have a couple slides about cost. Here's the cost comparison when you look at treatment versus smoking. This is taken from the website RX for Change, and the data is approximately 3 or 4 years old. But I think the point is a good point to be made. And that is, on average, you're going to get more bang for your buck if you use Chantix, the patch, or the nasal spray, interestingly enough, versus some of the other stuff that's out there. But the point of this slide is that the cost of cigarettes is quite similar on a daily basis if you're a 1-pack-a-day smoker to the cost of most of these treatments, which vary in price from $3 some to about $6. And again, as cigarettes get more and more expensive, depending on what state you live in, then these treatments will be more and more cost effective. I don't know what the record is now for the cost of a pack of cigarettes. I think in some states it's up to what, like $8 or $10. So,
one of the other pieces for this slide in thinking about cost comparison is all but the yellow bar are available by prescription. You can't get tobacco by prescription. But depending on your medical coverage, and all of Ohio Medicaid covers all of the different FDA-approved treatments. So from an out-of-pocket standpoint, if people go generic with a Medicaid card, they typically pay nothing. If they want to go with brand name, it's like $1 or $2 copay depending on the product. So again, if you're talking with someone who has some challenges about finances, pointing out that we can't write a prescription for tobacco, but we might be able to help with tobacco, nicotine patch.
Patches, yep. Okay, and this slide here looks at long-term, and by long-term they mean greater than 6-month quit rates. And one thing I want to point out about this slide is this study did not compare each method to the other. This study compared each method to placebo. So you'll see the active drug in yellow, the placebos in green, and so you can sort of see what quit rate did you get with active drug versus placebo. So you can see that in most cases, the active drug is double the rate of placebo in getting people to quit, and that the quit rates vary from 15% to about 24%. That's pretty good, because when you look at, sort of the cold turkey quit rates, they're down around, 5 to 8%. Okay, so let me summarize here on tobacco use and serious mental illness. And again, you have seen this slide before, because it's just an important one. So we've already reviewed the morbidity and mortality. We've reviewed that people with serious mental illness smoke more. We reviewed the pharmacological treatment aspects, and we reviewed the different interventions. Okay, at the cost of beating a dead horse, I will remind you that pharmacological treatment doubles the quit rate compared to placebo, and that when you mix treatments together, you actually improve outcomes. So Wellbutrin plus the lozenge, the patch plus the lozenge, etc., those have better outcomes than using either one alone. Here's the part that's FDA off-label. When you use higher doses, and if you've used longer duration than what it says on the package insert, that may actually be beneficial. And as I alluded to earlier, and as one of our people on this video conference already stated, there might be implications that, hey, some people might have to be on this stuff for life, okay, or at least for a very long time. Not just 6 weeks, not just 6 months, but maybe 6 years. So I don't think that's out of the realm. I guess I would, agree with that. And I've had my own personal experience with my patient. Hey, she was on the nicotine lozenges for 5 years. I told her, keep taking it. As long as you're not smoking, I'm okay with it. So, it really depends on what the person wants to take, what the cost is. Do they tolerate the side effects? That usually will help us, as it does in most things, to guide our decision making. The last slides here. This is one of my favorite slides, and this is a reminder that tobacco intervention is everybody's job. It doesn't matter if we work in primary care, or if we work in mental health, or if we work in primary addiction treatment, or if we work in all three settings. It's still our job to talk about tobacco to any of our clients that is willing to listen. So it is certainly everybody's job, and I'm pleased that there's a good response around the state for people that want to hear about it. What I have here on the next two slides is a list of helpful resources, which includes our own Ohio Tobacco Quit Line, which has a number as well as a website. You also see the Surgeon General's tobacco website, lots of helpful resources. We've thrown on there the American Lung Association, the National Cancer Institute. They have their own telephone quit lines, which I believe are national. Those are national quit lines. The Ohio quit line is just statewide. And then you also have the Ohio Medicaid prescription coverage website, which basically shows you what's covered in which part of the state of Ohio. And I also wanted you to be aware of the CDC website, smokefree.gov. The New Jersey is a state, because of Dr. Jill Williams, New Jersey is a state that's really taken this on as a cause. And they have their own website called tobaccoprogram.org. They also do trainings, I believe, twice a year. It's a 3-day training. It's a really, really good training. I took it 3 years ago. And then on the West Coast, University of California, San Francisco has started a smoking cessation leadership center. And out of that leadership center came what I think is one of the best websites to date on this topic, and it's called RX for Change. It includes free slides, free case studies. It includes training for every subspecialty known. So it's got training for surgeons, training for psychiatrists, training for nurses, training for pharmacists, training for PAs. So it's ways to train all different kinds of professionals, health professionals, and you just have to register on the website so they know you're not fooling around. They actually ask for name, address, phone number, etc. But then you have free access to the training curriculum, and that's rxforchange.ucsf.edu. And I've joined that website. It's a good one. And some of the materials you have in your folder are straight off the RX for Change website. So I do want to thank everybody for their attention and their patience with the technology today. And I hope that, like I said at the beginning, that you're as fired up about this topic as I am now. So.
I did want to comment a little bit about the use of Varenicline, and we've been trying to poll providers across the state for their experiences with it. And so we have a couple of providers that are using it relatively extensively, and we're talking about 20 or so folks that have tried it, maybe a little bit more, and have not seen any of the suicidal or homicidal problems or side effects, definitely with the vivid dreams. But people expecting that it might happen are able to tolerate it or work through. Again, this is purely anecdotal. This is just to let you know, if people have other experiences, please share them with us, because we would like to start gathering some information so we could just help people make really good informed decisions. Again, I need to thank Chris for joining me, as well as our partners, Lon Herman and Jonas Tom and Dr. Sherman from ODMH. We really appreciate people's time and energy. It makes us feel really good when we see the turnout and we see the energy that people have around this topic. Because again, if we get back to our little roadkill slide, we definitely believe that tobacco intervention is everyone's job. And so we hope that we've brought at least a few of you potentially out of contemplation into preparation or action. A reminder, we are working with providers throughout the state of Ohio to help them learn whatever it is they need or want to learn, so they can, again, effectively work with folks on how to address tobacco. So you have our contact information. Please feel free to get in touch with myself or Dr. Chris or Patrick Boyle if you need or want more information or just want to hear, what's available. Please make sure you've signed in legibly, and that you turn in your forms and your evaluations. Hopefully this was helpful to people. If you have any other feedback, questions that come up afterwards, or other topics that you would like to see or hear, please let us know. So again, I thank everyone for your attention. Take care.